Hello, everyone, and welcome back. My name again is Steve Hendrix, and I'm the president here at m.Care. So this is the third podcast in our series. It's our second one with Dr. Tom Hale, who's joined us again here this afternoon. So in our last podcast, Dr. Hale shared with you really his experiences and his vision of what's going on in the healthcare industry today. The paradigm's changing. We're moving into value-based care, but the healthcare industry really wasn't ready for a new model. And so there's a lot of disruption taking place in the healthcare industry. Now we're going to transition to some real-world experience. Call it a real-life case study, as Tom was the executive medical director at Mercy Virtual when Mercy Health decided to stand up what we like to call the world's first hospital without beds. And Tom can comment on that as well. Tom, are you with us?
Right here, Steve. Anxious to have a discussion.
Awesome. Thank you for joining us again. So again, we want to get down to what I'll call real-world examples. Tell us a little bit more about the vision that you had initially for the Mercy Virtual Center, how it all kind of came to be, and just bring us up maybe to that point when it was up and running and things were exciting, because I was there and it was fascinating what you all were able to do. Share a little bit of that story with our audience today.
No, I appreciate that, Steve. So if you remember, what we talked about last time was a little brief discussion around what's different in healthcare now. What's the burning platform? And just to reiterate, and we all agree that the cost of healthcare is unsustainable, and we know that patients are becoming consumers of healthcare. All you have to do is be a physician in your office, and the patient comes in and tells you what they learned on the internet and wants you to comment on that. Payments are moving to value-based, revenues shifting to the ambulatory setting, and instead of procedures and utilization being the unit of measure is now how many lives, how many patients are you managing? Inpatient utilization, just by the nature of technology, actually is decreasing. As we had spoken about earlier, bypasses have gone from 2 weeks in the hospital to 3 days to some procedures actually happening as an outpatient. Competition for the healthcare dollar continues to grow. And as we've spoken about last time as well, that comes from non-traditional sources. I mean, who you got Apple that's going to send you, I read an article the other day that Apple says you don't need to go see the physician. We can do your physical for you.
Yeah.
Scary thought.
I saw that.
So providers and physicians, they have consolidated, but even without the consolidation, we're seeing a significant shortage of providers and nurses, particularly in the primary care aspect. So, and I think that the other aspect that we talked about was that the physicians and the providers and nurses and even the patients are not really prepared for the change at the present time. So we were sitting there, these were the things that were happening as we were starting to discuss all our things around innovation that we had been researching and trying some aspects. The first was actually telemedicine, the old television medicine, where we would actually have video visits with patients. But that rapidly began to evolve, and we formulated what we thought was actually wasn't telemedicine that we were interested in. It was actually virtual care, which has now actually become pretty much a byword across the industry. And our view of virtual care was a triad of technology, your video visits, your monitors, your software platforms. It was also about analytics and data. We had this big push that was formulated over time of putting electronic medical records in all physicians and hospitals. And through that, we've gained a significant amount of data, much of which we haven't known what to do with, but are beginning to learn how that data can support our decisions and select the right patients to care for. But we also brought some aspects of what we thought was important from historically physicians. What we think and what we call the art of medicine is really all about relationships between the physicians and patients. So how can you take those three aspects and create a model of care that will battle those burning platform issues that we had talked about before.
Right.
So naturally, being part of the Sisters of Mercy when I was doing this, the sisters always told us no margin, no mission. So we want to do the right thing for patients, but we also have to find a financial model that would allow us to do those types of things. Well, that's where healthcare economics in the United States is really interesting, because we spend $3 trillion in a year around healthcare within the United States. We invest in lifestyle modification and personal choices. That is something we need to be cognizant about, and it is an important aspect of our caring for patients. And we also react to disease and acute care. Unfortunately, in that case, our biggest monitor is actually the patient themselves, and the patient becomes our alert system when they show up at the emergency room or they call the physician.
Right.
Of course, I'm sure, Steve, you've never called your physician late at night.
Never.
So, but the third thing is what I've labeled stupid stuff. It's $1 trillion of wasted resources on things that didn't need to happen, and that's all about increasing access so that people know that they can get hold of their provider, and decreasing variation in the care delivery model. So at Mercy, it didn't like this happened overnight. We actually had been in the EICU business for about 6 years before we started to begin to expand. And the EICU taught us quite a bit, actually. And what it taught us was that it isn't about Superman moments. It isn't like you're going to make this tremendous diagnosis on someone like in my day it was Marcus Welby. It's probably House now, or maybe it's even some other medical show. It's actually about meat and potatoes. Is the medicine the correct medicine that the patient's getting? Is the head of the bed elevated? Do they have their stockings on? All those things that are the day-to-day aspects that we overlook, but are so important in patient care. The second thing we learned, Steve, and you were part of this as we started to work with m.Care, as one of our abilities to be able to interact with patients, and that was around sepsis. And what we learned with sepsis was that if you collect the data on a patient and you centralize that data to be reviewed by one or two people, you decrease the variation in care. And then you rework the workflow so that instead of processing that back out to a largely distributed group of physicians and providers, you send it to a rapid response team. And because of that, we significantly impacted our sepsis and severe sepsis mortality and morbidity, and we're able to sustain that type of model. But it also taught us not only the centralization in order to decrease variation and reworking the workflows, but it taught us that everybody would benefit from being monitored in a hospital in every acute bed. And I think that you'll see hospitals headed in that system. However, we also began to understand that perhaps monitoring and providing that access to care and decreasing variation in the ambulatory setting might have a significant impact. And where that has, once again, it's as the wasted $1 trillion, another opportunity, and healthcare is a little bit interesting in that regards, and that's that 5% of the people spend 50% of the dollars. And so what we did was, and this is where you and I and the rest of the gang at m.Care got together, was we created a model of care where we put monitors, Bluetooth monitors, and we put smart devices, and you all built the best interface I've ever seen for patient engagement interface. And then we put that core team together centrally like we did in sepsis. And then we followed that it's about meat and potatoes, and gave that patient 24/7 access and decreased the variation in care. And you know what the result was. It was, well, I'll give you an example. So our very first patient was Sweet Naomi. You know, Sweet
Naomi, you betcha.
She's a delightful little lady. And Sweet Naomi had two primary cancers. She was on Homo 2, but she was at home, and all she wanted to make sure was that she could stay at home and that she could hobnob with her two daughters, who were very attentive, and could play bingos on Tuesday nights. In Naomi's case, the year before we put her in the program, she was hospitalized over 10 times and was in the emergency room about 9 times. Her total cost for that period of time was about $500,000, as you would expect for somebody with the conditions that she had.
Right.
Because we were able to utilize the m.Care platform to interface with that patient, and because we put that centralized group of caregivers, the nurses and the social workers and the physician, and because we had the monitors in place, all of that together, Naomi, who lived another 8 months while she was in the program, stayed at home, played bingo every Tuesday night, and gave her daughters all kinds of trouble.
Absolutely.
And during that 8-month period of time, she was only hospitalized 1 time, and that was an overnight stay. That's the kind of impact that we began to understand and realize, both through our historical pieces where we were with the EICU and the sepsis program, but also because m.Care gave us the ability to be able to engage with that patient.
Yeah, I think that was a really key component of the success of the program. Is Thank you for the plug for m.Care, by the way, and we'll be covering that in a future podcast. But the technology platform coupled with the clinical team at Mercy Virtual, and then a motivated patient population. Like Naomi, most of the patients were elderly. They were geographically challenged, technically challenged, physically challenged, and yet we were able to provide a platform and then this constant touch by your clinical staff. And so these people were able to stay at home. They had constant communication with the clinical team. They were using the technology to communicate data so that they could be better managed and monitored. I mean, it was a perfect trifecta, if you will. We had the right clinical people, the right technology, and a motivated patient population who just wanted to stay home. They didn't want to drive that 2 hours to the nearest healthcare facility. And so we achieved, as you know, tremendous results. The case study that we keep referring to said that we reduced the cost of care by something like 60%. We reduced ER visits and readmissions by over 50%. But the one that I like the most, that I know you and I have talked about, is the fact that 93% of that patient population touched our app in one form or fashion every single day. And the reason they did that, they knew if they stayed compliant and they stayed in touch with their clinical team, they were going to be able to stay at home. And that was their driver. That was their motivation. So it's really a phenomenal program. I remember some of the quotes you guys have in the garage from some of the patients, and the value that they felt out of the program was just heartwarming. And so, yeah, I love the pictures of Naomi. We've used pictures in her story many, many times. So she lives on in our hearts for sure.
So Steve, you pointed out some things that I think we need to accentuate a little bit, because there's urban myths everywhere. And one of the urban myths that I hear all the time is that, well, the elderly can't use technology.
Mm-hmm.
That is absolutely baloney. First off, Naomi used it just fine, as did the rest of the patients that were in the program. But my classic is the worst thing I ever did was give my mother at 93 an iPad and taught her how to send me emails and texts. Oh my goodness, my life was never the same. And she carried that on until she passed at the age of 97 and a half. The elderly absolutely can use the technology.
Absolutely.
But it also has to be the interface. I'll give you guys kudos again. You have to have the interface of the patient engagement platform that is responsive for people, so that it isn't technically challenging for them to be able to communicate with their caregivers.
Yeah. No, I think you're spot on, Tom.
Steve, the other aspect that I think people need to understand is that this is an augmentation strategy. This does not replace This did not replace Naomi's physician. Naomi
Right.
still went to see her primary care physician, still
Good
saw
point.
her specialist,
Yep.
and we made sure that she had transportation. And because we had that team that was behind her, you almost begin to think you're a Verizon commercial where you're all that massive team behind Naomi.
Right.
But also, it is the case because of that augmentation that we don't sever that relationship. That's core to what we want to maintain, is that relationship between the physician and the patient, and the caregivers and the patient. I think it is important to point that out. And despite the extra cost that it was to put that program together, as you pointed out, it was so impactful that the return on investment was almost five to one from the cost it took to put the program in place to the savings that we attained through value payments like Medicare Advantage and MSSP moving forward.
Absolutely. So just for a bit of clarity for the audience, so the virtual care model, it works great in all demographics. We have seen examples, and Tom's familiar with this as well. It works in our pediatric programs. It works in our senior programs. So it's not limited to a demographic. It's limited only by the imagination of the clinical team and how they want to work with, monitor, and manage a patient population that's at home. So I think that's what I'm excited about. I know that's what Dr. Hale's excited about, is leveraging the clinical know-how and knowledge, coupling it with technology, and producing the kind of results that we saw at Mercy Virtual and we see in other implementations. So thank you, Dr. Hale. I think this has been super interesting and informative, and we're looking forward to the last in our series of podcasts, where we're going to really talk about, now, how do we take this, what I'll call proof of concept, this case study, how do we now take it forward and populate it in the healthcare industry? How do we move the needle? And we'll be anxious to hear your thoughts on that.
Great, Steve. See you next time.
All right, sounds good. So to the audience, thank you again for listening today. My email address is steveh@m.care. We encourage you to send in questions that we'll answer in future podcasts, and look forward to receiving those from the audience. With that said, that ends today. Thank you for your time. Appreciate it. Goodbye.